Okay, let's begin. Thank you all for being on time, for joining us this evening. We are here for the Gastroenterology Symposium hosted by SAJAC. My name is Kaylee. I'll be hosting the symposium this evening. And I say this every time, but for those who don't know me, I am Renee and Charlie Frank's granddaughter. I'm also the newest board member of SAJAC. I'm a health and life insurance broker, and I am the resident Zoom whiz, hence why I am hosting all of these. This evening is a continuation of a very successful series of medical symposiums that we've organized since the start of the pandemic. We're joined today by a few speakers who are leaders in the field of gastroenterology, and we'll each be discussing different aspects of the topic. I ask that you be sure to write any questions you may have in the Q&A box, not the chat. And we will be doing our best to answer all of those at the end of the evening. I also want to make sure you know that this is a recorded webinar. So if anyone has an issue with that, letting you know, you will also be able to see a recorded version of this afterwards. So without further ado, let's begin. Our first speaker is Dr. Richard Boland. He is a gastroenterologist and professor of medicine at the University of California, San Diego School of Medicine. He's from upstate New York and received his BA from the University of Notre Dame, an MD from Yale Medical School, and he has a career-long research interest in colon cancer, specifically focusing on the topic of genetic causes of colon cancer and familial cancer syndromes. He was among the first gastroenterologists to explore microsatellite instability, also known as MSI, in cancer, and his laboratory developed the first in vitro models to study the basic biology of MSI and Lynch syndrome. In recent years, he has contributed to our understanding of the genetic and epigenetic basis of colorectal cancer. Dr. Boland has been an active clinician, teacher, and mentor. He was elected into the Association of American Physicians in 2001 and has both earned awards from and held positions on many other prestigious associations. He also is a member of the Greater San Diego and Desert Area chapter of the Crohn's and Colitis Foundation. So if you could please switch on your camera and your microphone, I'll turn mine off and get going. Let me share the screen here.
Thank you. I'm going to make a little change here. Okay. So thank you for this opportunity to talk to you about something that I've been thinking about, working on for about 50 years. And when I started it, there was no way you could guess where we would be with this problem, like over the 40 or 50 years of research. We've just gotten to a place that's just incredible because we had no way to control the disease. We didn't know much about it when I started out. And when I said to some professors when I was a medical student that I thought that there might be a familial form of it, they said, well, that's really not true. And if you think that's the case, go prove it. So anyways, if I could have the next slide. So I'm just going to give you the high points of this. We're not going to get deep in the weeds here, but colorectal cancer is a common problem. And in 2018, there were 4.8 million cases of gastrointestinal cancers worldwide, and colorectal cancer is the biggest of that bunch. It's 26% of the global GI cancer incidence. A lot of deaths worldwide. So it's most common in the Western world, wherever the Western lifestyle is practiced. North America, Northwest Europe, Australia. And interestingly, when I was a student, colon cancer was conspicuously low in Japan. And then after the end of World War II, as they changed lifestyle, they smoked more, they ate more of a Western diet, it went up and it surpassed what we see in the West now. In the US, In 2020, there were 148,000 cases, 53,000 deaths. And what I'm going to show you is that the incidence is falling now, which is very gratifying. Oops, you can give me the bottom half of that. Yeah. And there's something strange going on in which the incidence has been creeping up in people under the age of 50. And we don't know about that. A lot of people are working on it. So could I have the next slide, please? So the principal risk factor for colon cancer, as you can see on the is my cursor showing up? I guess not. Okay, so it's an issue of age. I mean, you don't have to be, a serious scientist to recognize what's going on here. The older you get, the more likely you are to develop this disease. Now, in the upper left, that's this issue of early onset colon cancer. And a woman in the American Cancer Society named Rebecca Siegel recognized that that there was something happening and people under the age of 50 were getting an increase in the incidence of colon cancer, and they weren't being screened. And we've actually made recommendations to back up the screening age to 45 because of this. And we don't really know why, and it's an especially deadly disease in that case. Next slide, please. Oops, yeah, there it was. Yeah, that was the ages 50 to 59 there. Now, in this particular slide, what I'm trying to show is the relationship between gender and colon cancer. And as you can see, it's a little worse in men than in women, whether we're looking at the colon or in the rectum. I think this is probably mainly driven by hormonal factors, because women have a lower incidence until menopause, and then it's parallel to the incidence in men. Women don't ever catch men because they were behind during the menstruating years. But once the estrogen levels fall, then the curves go up about in parallel. Next slide, please. Now the colon's a 3 or 4 foot long organ. You may not know this. It's a little bit longer in women, a little more twisty in women than it is in men. And women, the disease is a little different in men and women. So there's a higher incidence of proximal cancers. That would be the right side of the colon. And interestingly, the molecular features are different too on those right-sided colons. And it seems to be driven more by smoking, the things that are happening. But it's not hugely different. The whole colon is at risk. In the early onset cancer, that's under age 50, the overall incidence is pretty low, but it's going up. You can see that's more of a distal disease with more distal colon and rectal tumors. Next slide, please. So here is some pretty decent news. And the trends are for the incidence and the mortality to be going down in both men and women. And you see that it's gone down in a steeper way in men than women, who started off higher. And we don't know if at some point those curves will come together. We think that I think it probably will never completely come together because of the hormonal differences between men and women. But as we stop smoking and as the diets improve, this should continue to go down. Now I'm going to show you too that it's no mistake. I can't read the numbers on here because it's kind of small, but this fall in incidence that we're seeing is really related to screening and taking out pre-malignant polyps. That's the main thing that we're seeing there. Next slide, please. So the risk factors are: age is a very strong factor. Next, gender, somewhat worse in men than women. Next, historically, it's been worse in African Americans, but what's interesting is that's now falling to the Euro-American rates and increased. There's also a pretty high incidence in American Indians too, presumably because of diet American Indians are not particularly big smokers. There are lower risks next in Asian, Pacific Islanders and Hispanic Americans. And there have been key risk changes over time. So, for example, I mentioned earlier, historically the rates were low in Japan, but then there was a sharp increase since the 1970s. And it's been falling in the US since screening began. And now screening is becoming more popular in Europe, so it will fall there too. Then there's I've got a slide on family history and genetic factors, but the main factors are lifestyle based: obesity, Western diet, high fat diet, meat, and smoking. And interestingly, and we didn't realize this 40 or 50 years ago, smoking is a pretty strong factor. And so that's one of the things that's made the incidence go down in the past decades. Next slide, please. Okay, let's take a look at genetic factors. Now, most colon cancer is sporadic. In other words, it's not linked to a strong genetic factor, but there are a couple of disease entities that make the incidence very high to get a colon cancer during your lifetime. One are called the polyposis syndromes, and there's a whole bunch of them. Some of them, the most prevalent one is called FAP, or familial adenomatous polyposis. That's not very common. It's 1 in 5 to 10,000 people. There are a bunch of recessive diseases that have been found, and interestingly, a recessive disease is completely genetic, but it may look not familial because you need to get the gene from both sides of the family. So it will look a little bit more hereditary in families that are more highly inbred, but in outbred communities, like in most of America, they look sporadic. So familial polyposis syndrome accounts for less than 1% of all colorectal cancers. One thing that might be relevant to this audience is that the gene that causes FAP is the APC gene. It's the adenomatous polyposis coli gene. And there's one variant that's found almost exclusively in Jewish populations, and 6 to 12% of Ashkenazim carry this. And when it was first reported, it was thought that it increased your risk of getting colon cancer 1.5% to 2%. But every time a new study comes out, somebody gets slightly different data. Sometimes they show no increase in risk, and sometimes they show an increase. And what happens is you get a mild form of polyposis, later onset, fewer polyps. But that's one thing that might come up. And if you got genetic testing, that would come up in some proportion of people. And then there's the non-polyposis hereditary colorectal cancer syndromes, which are more common, and that's Lynch syndrome and variations on that theme. It's been recently shown that 1 in 279 people in the Western world have Lynch syndrome, so it's really pretty common. And most of them, 90% of the people who have Lynch syndrome, are unaware of it. It's autosomal dominant, so you only need to get the mutated gene from one side of the family. And when it comes in, then half the offspring are affected. Now, there's an issue of penetrance, and depending upon, there are 4 different genes that can cause Lynch syndrome, and there's lots and thousands of different pathological variants or mutations that can occur, and that will create variability in how likely you are to get a cancer, even if you inherit the gene. And we now know that the penetrance is probably about 50%. In other words, it's not an overwhelming penetrance, and that's what makes it more of a complicated disease, because some people will suddenly get this disease and they say, well, there wasn't any cancer in my family, and that can happen that way. There are very good genetic tests to diagnose this. There are very good tests to screen for this. And there's a specific test that you do on the tumor, and that's a test for microsatellite instability. And if that's positive, then there's some likelihood that you have Lynch syndrome. There's another sporadic variety that accounts for 3/4 of those. But if it's a young person with microsatellite instability, then Lynch syndrome is high up on the list of possibilities. Next slide, please. So screening. So in the early days of screening, like when I was in training, sigmoidoscopy and a guaiac test, a fecal occult blood test, were used to try to screen for it. And those really weren't too good. The sigmoidoscopy could only find tumors in the bottom end of the colon and in the rectum, and the fecal occult blood tests were often positive falsely. So so the idea was to start this at age 50, and it was good for finding large cancers, but the whole point was to find smaller early stage cancers. So now, and then when you had a positive test, you'd get a barium enema. But at around 2000, colonoscopy was finally recommended and accepted for healthy individuals, and we started at age 50. Now, the likelihood of finding a colon cancer, and I hope this doesn't get anybody too upset, the likelihood at age 50 of having a colon cancer is about 1 in 1,000. The real reason to do the colonoscopy at age 50 is to find polyps, take those polyps out, and the people who have polyps need to get more frequent follow-up colonoscopy, whereas if you don't have any polyps, then you can wait 10 years to get the next test done. And now we've just pushed back the starting date to about age 45. I think that's the next slide, yeah, because of this early onset colon cancer. Now, what's also available is that, first of all, the newer tests for occult blood in the stool are way better than the initial test that we have. It's quantitative, in fact. And the current test FIT test can detect about 81% of colon cancer. So you really need to do it over and over, year after year. And colon cancers grow pretty slowly. So if there's a very early, not yet malignant large polyp, it doesn't matter so much if you miss it 1 year, because you'll pick it up the next year, because it takes lots of years, probably a decade or two, for a small polyp to turn into a cancer. And the non-colonoscopy approaches have considerably improved. The fecal-based tests are way better. There's a DNA-based test that can be done too, but it's very expensive. And so I'm not a big fan of that particular test. I think the best way to screen for colon cancer is to get a colonoscopy at age 50. And if you don't want to have that done, then get a fecal immunochemical test for blood every year. And then if that's positive, then you get a colonoscopy. Next slide, please. So here's what's happened here. As you can see, as the number of colonoscopies went from 20% to I think it's 61% on there, the incidence of cancer has fallen. So taking out benign precursor lesions or adenomatous polyps has a big impact on getting an advanced cancer later. And there aren't that many cancers in which you can literally prevent it with the intervention. In other words, mammography is excellent for finding early stage breast cancers, but it won't get rid of that early cancer, whereas colonoscopy can do that. So that's the good news, is that red line going down. And conceivably, as more and more people accept this, then it will continue to fall. Next slide, please. So you might say, so what's the screening rates in the U.S. by state? And you can see there's a pretty big range, in which you got Massachusetts and some other places over here, and then some other states just don't want to go for that. And if you give me the next slide, you might want to know where California is. Whoops, back it up. Yeah, see, it's right there. So we're doing pretty well in California. And as long as we can get colonoscopies done, do them safely, take out polyps, and then prioritize who needs to get another test later, we should continue to see a fall in the incidence of colon cancer. Next slide, please. Now, in 1994, the American Cancer Society did a big study, and they were trying to find what foods might cause colon cancer. And they just had a very small amount of pharmacological data, but they included aspirin. And that was probably the most important factor. And what happened was that if people who took any aspirin per month had a 5% reduction in their mortality for colon cancer. But the people who took 16 or more doses a month, which included all the people who had rheumatoid arthritis and were taking big doses, they had a 40% reduction in mortality. And so that was really the first news that aspirin really could prevent colon cancer. Now, there's been a lot of debate about this and different studies in the literature, and here's what has made it confusing. If you start taking aspirin, it takes about 10 years before the people who take aspirin get fewer cancers than the people who weren't taking it. So when people have done studies of 2 and 3 and 4 years, you don't see it. It takes a long time. What's also interesting is in the case of Lynch syndrome, a big study was done in England in which they gave very large doses, like 2 adult aspirins a day. And in England, that was 600 milligrams. In this country, that would be 650 milligrams. And there was also a 40% reduction in colon cancer and in the other cancers that occur in Lynch syndrome. So aspirin's a pretty good anti-cancer drug, particularly in the colon. The question that has been coming up is there a time when you should stop taking it? And generally people think that somewhere in the 60s, that your risk of getting a complication of aspirin might be greater than the protective effects. So probably somewhere in the 30s and 40s, it's not a bad idea to start taking some dose of aspirin. We don't really know the dose. When I saw that study in 1994, I started taking 1 adult aspirin a day for like a long, long time. And then I've had discussions with other people. Some people say, well, I'll just take a baby aspirin, 81 milligrams, and maybe that will help. But it looks like there's a dose response. So the bigger dose that you take, the fewer colon cancers you'll have. Just the problem is the bigger dose that you take, the more likely you are to get belly aches or an ulcer or bleeding or something like that. Next slide. So when somebody gives this talk 5 or 10 years from now, it's going to be different. We're doing a lot more testing of fecal DNA. So what happens is that the colon cancers are caused by mutations in DNA, and then those cells get shed into the stool, and you can detect that. And there's a test right now that's out there that I think is too expensive and not specific enough to be used for everybody, but lots of companies are working on trying to come up with a new approach to this. And they're also using different types of RNAs like messenger RNAs and microRNAs and methylated DNA, lots of other approaches. And I think that eventually we're going to find the right combination. There doesn't appear to be one DNA test or RNA test that will really tell us what we want to know, but there'll be some combination of them. And it'll come as a big kit, and we'll probably test the stool, and that will be the best way to go. Now, there are also blood tests that are in the pipeline, but there was just a review that came out, I just saw it yesterday, in which there are 6 new approaches. None of them is ready for prime time yet, but some look very promising. I think the big problem we're going to run into is that a cancer from anywhere, a breast cancer, a colon cancer, a prostate cancer, whatever, is going to probably shed cells into the blood. And I think that the challenge is going to be to sort out where that tumor is coming from. And probably every tumor will have a unique signature. But keep tuned. Someday we might be able to walk in, get a blood test, and if it's a negative, that may permit us to put off any colonoscopy or some invasive thing for another year or 2 or longer. And also there are new imaging tests too, and there's something called capsule endoscopy. Again, not quite ready for prime time, but you swallow this like a big horse pill, and it takes a movie of the inside of your colon. Now, no one knows how good it is just yet, but well, there have been several studies. We know it's not perfect, but there are going to be some new ways of getting at the imaging of the inside of the colon that will help us out. So there's a lot that's in the pipeline right now, and there's reason to be optimistic. And I'll have to say, based upon what I saw when I was a medical student, through my training and over the years, I've just been blown away by the progress. So there's no reason to believe that that's going to stop. And I think this is my last slide, the next one. And it's got my, oops. Well, there was a slide that was in there that had my email address on it, but
I wrapped those all up into one slide at the very end.
oh, okay. So if anybody has a specific question, or maybe you just don't feel like asking it in front of everybody, then you send me an email. I'll be glad to answer that. So there you have it.
Thank you so much, Rick. We appreciate all your insight. That being said, we are going to move on to Angelina Collins, our next speaker here. So Angelina is a board-certified adult nurse practitioner. She received her undergraduate degree from the American University and her nursing and master's in nursing from the University of San Diego. She's been a GI nurse practitioner for 15 years. Her interest and passion for inflammatory bowel disease developed while working at a large private GI practice in North County before joining Dr. Sanborn at UCSD. She provides comprehensive care for patients with all stages of Crohn's disease and ulcerative colitis, from the newly diagnosed to those who have long-standing disease and complications, as well as patients in clinical trials. In addition to lecturing at local and national IBD conferences, Angelina is a board member and medical advisory committee member of the Greater San Diego and Desert Area chapter of the Crohn's and Colitis Foundation. So with all of that, let's share the screen again and take it away, Angelina.
Well, thank you so much, everybody. I appreciate everyone joining tonight. For some of you who may know me, I love talking about inflammatory bowel disease. So this is going to take a bit of a departure from the colorectal cancer screening talk that we just had. And I have to admit, I learned a lot of interesting pieces there. So thank you, Dr. Boland, for all of that. We appreciate it very much. So we're going to talk about inflammatory bowel disease. So just a few things that we'll do is just going through and trying to explain what is inflammatory bowel disease, look at some of the causes, some of the symptoms and diagnosis pathway, and then talk about the goals of care. And then Dr. Bridget Boland is going to pick up and talk about medication therapies and management strategies. So next slide, please. So what is inflammatory bowel disease? So this is an umbrella term that's used to describe the two most common diseases, which are Crohn's disease and ulcerative colitis. Next, there is a third thing that is sometimes called indeterminate colitis. And this is a bit confusing for a lot of people, but sometimes when there is ulcerative colitis or features that look like ulcerative colitis, and it's very tough to distinguish between ulcerative colitis or Crohn's disease, maybe there's features of both of these when the disease is located in the large intestine. This is really sometimes when people get labeled as indeterminate colitis. Now, a common misperception is that some people will say, well, I don't know if I have ulcerative colitis, or do I have ulcerative colitis and Crohn's disease? The answer is no. Usually you only have one or the other, but occasionally, maybe 5 or 10% of people where it originally looks like maybe it's ulcerative colitis, may have a change in diagnosis to Crohn's disease at a later time. But generally speaking, the disease you have at diagnosis is what's going to stick. And I'll go into some more details as we go through. Next, please. So what is IBD? It's a chronic, progressive, immune-mediated inflammatory disease of the digestive tract. So the digestive tract is another way of saying the GI tract or GI system. So that would be the best way to kind of explain it. It's a chronic disease. It is something that when you're diagnosed with it, you're going to have it, much like some other conditions where you'll have it for life. Unfortunately, we don't have a cure for it. It's generally characterized by periods of flares and remission. It's typically diagnosed in people under age 30. So you can imagine what this is like for people that have never had any prior diagnosis and the age in which they're being diagnosed. This can be a highly life-altering and life-changing condition. So you can imagine all the different experiences people have when you think about Crohn's or ulcerative colitis. It affects about 3.1 million adults in the US. It's about 1.3% of the US population. So it's not as common as maybe another disease state, but certainly for the people that are affected, it is it's a major disease. And because of the implications on what happened, and because they are progressive, these are something that affect people for their life. What IBD is not, and this often gets confused, and I think, one real important takeaway is that inflammatory bowel disease is not IBS or irritable bowel syndrome. These are two separate things. And I think it's really important to kind of consider that. So irritable bowel syndrome is something that affects millions of people. It's the feeling that people either usually they have more constipation or diarrhea plus abdominal pain. So sometimes the symptoms may look similar, but if you were to do a colonoscopy, then you would not see inflammation for somebody who has irritable bowel syndrome. However, with inflammatory bowel disease, there's inflammation. So you actually see signs of inflammation when you're doing a colonoscopy or flexible sigmoidoscopy or a scope inside the body. So hopefully that explains just a little bit about those two things. I think they're often confused, even for people that have Crohn's disease or ulcerative colitis, or sometimes they get confused on IBD, IBS, because they all sound very, very, very similar. Next, please. I wanted to show some famous faces of inflammatory bowel disease because I think most of my patients will really tell you that they feel like this is a disease of isolation, or this is something that people don't want to talk about because obviously talking about bowel movements and talking about poop is not always it's not usually very glamorous. So it's really wonderful where there's famous faces who actually are willing to discuss their disease. And it's also awesome to see these famous faces. One, an Olympian swimmer, Kathleen Baker, who's up on the left-hand side. Then there is Amy Brenneman. There's pitcher Jake Diekman, which is very impressive. Our own local hero, the former San Diego Chargers kicker, is Rolf Benirschke. As many may know, he's super active in the world of Crohn's and ulcerative colitis locally, which is really fantastic. And I couldn't help but show everybody that even one of the minions obviously had Crohn's disease. If you see, this is like a perfect picture of what people sometimes with ulcerative colitis or Crohn's feel, because here's the minion who is shackled to the toilet, with toilet paper all around them, and this is what it looks like. So even minions are not unaffected by these diseases. Next, please. So what causes IBD? So this is an interesting way of trying to explain this. So what needs to happen for IBD to be present is there's sort of a convergence of three things. There's genetic susceptibility. So we know that there's genes involved in the development of inflammatory bowel disease. More than 200 genes have been identified. Some are bigger players than others. Some have a lesser role. Reality is, though, that of all the people that are diagnosed with inflammatory bowel disease, only about 10% of people actually have a first-degree relative that has inflammatory bowel disease. So in most situations, people may have a first-degree relative that have some kind of autoimmune disorder, or they may have another immune-mediated disease in the family, like psoriasis, type 1 diabetes, rheumatoid arthritis, or they may have lupus in the family, but they may generally not have Crohn's or ulcerative colitis in the family. So it's more common that you'd say that it's more likely to get Crohn's disease or to be diagnosed with Crohn's disease or ulcerative colitis if there's a first-degree family member, or if there's someone in your family that has an autoimmune condition, but that doesn't mean that you have to have that in order to be diagnosed. And by this, you understand that more people don't have a first-degree relative with Crohn's disease or ulcerative colitis. Interesting, too, that 2 to 4% more likelihood with Ashkenazi Jewish descent to see Crohn's disease or ulcerative colitis. So it's a convergence between this genetic susceptibility, an altered immune response. It's an overactive immune response where the body doesn't recognize essentially the good portions of the microbiome or the bacteria from the unhealthy portions and tends to kind of look at everything within the microbiome as being foreign invaders and as being bad. And so it's an overactive immune response against that and the environment. And so something is turning those genes on to start behaving in an abnormal way. And there's a few different pieces in the environment that we think are important. Certainly viruses and bacteria have been implicated. There's also smoking, especially for Crohn's disease, is a really bad predictor of Crohn's disease and more likelihood of having more severe disease. Anti-inflammatory use. So for example, like ibuprofen, as an example of that, is considered to have a negative association here, or have an association that increases the risk for Crohn's and ulcerative colitis. Just as some factors, there's some really interesting research going on these days about how diet can affect our body and affect our microbiome. And there's some questions about food preservatives, maybe emulsifiers, food colorings. It's been very interesting to see all of that. So it's really interesting to see all the research that's going on and have a better understanding of how these are playing together. But the reality is that we don't totally understand what causes inflammatory bowel disease. We know it's this interplay between these things, but we don't fully understand it, unfortunately, just yet. There's lots of people working on this, and so hopefully soon in some of our lifetimes, we will see some additional progress. Next, please. So normal GI anatomy, I just thought I should include this because I think it's all sometimes very confusing. So when we think about, what is normal anatomy, we start from the mouth and you think about the esophagus, the tube that leads into the stomach, and then the first part of the small intestine called the duodenum. There's 3 portions to the small intestine: the duodenum, the jejunum, and then the last portion is called the ileum. That leads into the large intestine, and the large intestine and the colon are named the same things. I joke with my patients, it's just we have to have multiple names so that you think we're important. So that's why we like to call things the same things. And then at the end of the large intestine, there's the last portion is called the rectum, and then the exit, basically, there's the anus, and then there's the exit. So that's what normal GI anatomy kind of looks like in this piece of the digestive tract. So next, please, because I want you to see that, and then I want to be able to show, well, how are ulcerative colitis and Crohn's disease a little bit different? So ulcerative colitis, we'll back up actually, because it's too much information for one thing at a time. So ulcerative colitis on the left-hand side of the screen. So ulcerative colitis only affects the large intestine or the colon. The rectum is almost always involved. About 90% of the time, the rectum is inflamed and irritated. And then it can, more of the colon can be, or more of the large intestine can be involved. But the rectum is almost always involved, and then can work its way upward in the large intestine. It is involved in a continuous fashion. So rectum, all of this is inflamed. It's usually graded as mild, moderate, or severe. People have very different courses of their disease. And I think that's really important, because if anyone is on this call right now and listening to this, they know, like, why is my disease different than someone else's disease, even in the same location? Why did they respond to one therapy and I'm not responding to this? There's a lot of questions we have, but I think it's really important to highlight and to understand that people have different courses. Everyone's unique on the outside. They have different disease courses that are happening and multiple different factors occurring on the inside. And we have to just appreciate that there are differences that are ongoing. And I really just want to highlight that, especially for anyone who knows someone who has Crohn's or ulcerative colitis. So contrast ulcerative colitis with the next portion of the slide. And here's Crohn's disease. So Crohn's can affect anywhere in the GI tract, anywhere from the mouth, just that normal anatomy that I just showed you, anywhere from the mouth all the way down to the anus can be affected with Crohn's disease. Usually the small intestine or the large intestine are involved. Another feature of Crohn's that's different than ulcerative colitis is there's often these skip lesions, or these areas that are affected. So you might be able to see where there's this inflammation. It looks that there's certain portions that are inflamed, followed by next to areas that are normal. So that's really one of the hallmark features of Crohn's disease, especially. Sometimes, though, disease is only just in one area, and I'll show you that in a couple of moments. The rectum is typically not involved with Crohn's disease. And then Crohn's is also labeled as either mild, moderate, or severe in the level of severity of inflammation. And with Crohn's disease, inflammation can lead to strictures, can lead to fistulas, abscesses, or even perianal involvement. So this can be a quite debilitating disease. Next slide, please. Now, in many ways, I say IBD is like real estate. Location, location, location is really important. And so when you look at ulcerative colitis, here's the distribution of how ulcerative colitis looks like at diagnosis. So when people are being diagnosed, if you look first on the left-hand side, there's some portion of people, maybe 30 to 60% of people, that would be initially diagnosed as only having ulcerative colitis that's confined to the very lowest portion of the large intestine, the rectum. So it's called ulcerative proctitis because of the location of the disease. The group in the middle, that would be left-sided colitis, because the left side of the colon is inflamed, the rest of the colon is not inflamed, and that affects about 16 to 45% of people at diagnosis. And then there's another group of people, about 15 to 35% of people, who have ulcerative colitis that affects their entire large intestine. What's interesting about any of these situations, especially for the two groups on the ulcerative proctitis group or the left-sided colitis group, is that 50% of patients that present initially with just a limited amount of disease go on to have progressive or pancolitis. So quite a number of people will progress over time. And so this is where I was saying at the beginning that ulcerative colitis and Crohn's disease are progressive diseases, and it's something to really kind of think about. So getting control of disease really is always really the best idea that we can have. So next slide, please. So Crohn's disease is a little different. So remember I was saying that Crohn's can affect anywhere in the body from the mouth all the way down to the anus. So next, please. So upper GI Crohn's disease affects about 10% of people with Crohn's disease. That's their location of their disease. About 30% of people that have Crohn's disease only have Crohn's disease in the small intestine. So that's generally, once you have Crohn's in one location, usually it generally tends to stay, give or take, in that particular area. And then about 45% of people are diagnosed with what we call ileocolonic Crohn's disease, or Crohn's disease that is between the area of the last portion of the small intestine, the first portion of the large intestine. So these names are derived based on where the Crohn's is located. So they get this big mouthful, ileocolonic Crohn's disease, but that's that area. And then about 20% of people only have Crohn's in their colon. So it only affects the large intestine. Usually affects just a portion of the large intestine, not the whole thing, but occasionally the whole thing. And then about 20 to 25% of people over their lifetime of having Crohn's disease will develop perianal disease, where there's inflammation that occurs down in the lower area. They have something called fistulas or abscesses, disease that comes, may tunnel between the inner portion of the intestine and the outside of the skin, or between two portions of intestine. And that would be perianal disease that's affecting basically the lowest portion of the intestine. Next, please. So remember what I was saying too, that location is important, because the location of the disease really will drive symptoms. And so the symptoms is basically what you feel, so what is somebody experiencing when they have inflammatory bowel disease? Well, for ulcerative colitis, one of the most common symptoms is actually diarrhea, or maybe bloody diarrhea or rectal bleeding. A lot of people have urgency where you feel like you have to go to the bathroom and you can't quite get there fast enough. It is, where you have like seconds sometimes just to get there in time. Many people have abdominal pain or cramps, or they may have rectal pain or cramps. So you feel it like at the very lowest part, especially when you're going to the bathroom. Some people have an opposite feeling. They don't feel like they have diarrhea. They feel like I have to go, but nothing comes out when I do need to go. And some people feel fatigue or they feel weakness. Some people have weight loss. So you can see there's a wide range of symptoms. And going back to what I said before, everyone's journey with their IBD is unique. And I think it's really important to kind of highlight that because these are some of the symptoms that people might have. Now with Crohn's disease, it's a little bit different. Next slide, please. So you see kind of abdominal pain or cramping is is higher up on the list. That along with diarrhea, you may see more commonly. Nausea and vomiting, weight loss or inability to gain weight, fatigue and weakness are also very common for Crohn's disease, and sometimes that's because of anemia. Fevers can occur as well. In the younger kiddos that are diagnosed with Crohn's disease, you may see the kiddos aren't growing as much as you might expect. So they may have growth failure or delayed growth or delayed puberty because they're not growing quite as much because of the disease. I mentioned anemia, which is a low blood count that can occur as a complication. There's some other nutritional complications that can occur as well. And some people get obstruction. Now, some people, next please, don't have any of these. These aren't their symptoms. And some people don't have any symptoms until they have more severe Crohn's disease. So again, everybody's journey is unique. And I think it's important to just mention that because if anyone's on who has Crohn's disease, they may say, this isn't what I feel at all, and that is well true. Everyone's journey is different. Next, please. Other things that people feel that I hear from patients all the time, especially when they're first getting diagnosed, is it's a struggle to understand these conditions. They probably have never heard of this before. I mentioned earlier that, essentially 90% of people don't have anyone in their family that has Crohn's disease or ulcerative colitis. So they've never heard of this before. And they're kind of trying to understand, like, how did I get this? What did I do that caused this? A lot of people feel sad or they might feel depressed about their, chronic diagnosis. They may be worry or anxiety about what's going to come next and tests. Sometimes parents feel guilt because they think that they did something to cause this to their child. They did not. But I think it's really important to just understand that you're not alone in this journey, that there are great support groups. I think it's really important to be open and honest and talk with your GI provider and find somebody that you can trust, because I think that these are the things that are important to share and to have someone help you through all of this journey. Next, please. So how is IBD diagnosed? So most importantly, the takeaway to this whole thing, most importantly, is to really think about the fact that it's important that you talk to someone, start with your primary care provider. If you're having any of these symptoms, make sure to talk with someone, get referred to a gastroenterologist or a GI specialist. Don't delay, especially if you're having something like rectal bleeding, or you're having, frequent diarrhea. It's important to get that referral to the gastroenterologist. We do know that by not getting a gastroenterology referral, that's likely to delay a diagnosis. So once you see the GI, yes, they'll probably be recommending tests, but the sooner you know what your diagnosis is and the sooner you can move on and move forward with strategies to help you start feeling better quickly. So typically you can expect that when you see a primary care or gastroenterologist, there's going to be lots of questions, right? So lots of questions. I always tell people, like, sorry, I'm going to ask you this question, but this is very normal for me. So I ask a lot of, probably odd questions the first time I meet someone about their, bowel habits and about pooping and this and that. And I'm like, this is normal for us. This is what we talk about all day long. So, I think that's the most important thing, is just to understand that all of the questions that we ask, it's just, this is what we hear about. And we want to make sure that we understand what your disease is like too. So doing a physical exam is typically important. Sometimes you can have video visits though, and you can kind of get started on this through a video visit. Blood tests are important. They can help us identify if there's inflammation in the body. Remember I was saying before that one of the differences between inflammatory bowel disease and irritable bowel syndrome is the presence of inflammation. So measurable inflammation is what we're often looking for, or signs of systemic illness in the body, like anemia, for example, or elevated platelets, or inflammatory markers. There's a really important stool test called fecal calprotectin. It can help us diagnose the difference actually between Crohn's disease, ulcerative colitis, and irritable bowel syndrome. So that's probably one of the more important tests that can be done to help us identify. It can be positive though also with infections. You have to be a little bit careful in how this gets interpreted, but it's a very useful test to help us determine if additional tests are needed. And then imaging is often important. CT scans or MRI, I'll show you a picture in a second. Colonoscopies with biopsies like the gold standard for diagnosing Crohn's and ulcerative colitis. And in the younger kiddos, they need endoscopies, or anyone who's having symptoms that seem more in parallel with upper GI illness need endoscopies, which is where you do a little scope down that way instead. Next, please. I'll just briefly show you, here is a picture of an MRI, but basically this is one of our important tests that we can do, that we have access to, where you can actually take pictures. You actually have special imaging. It's mostly this particular type of test is called an MRI enterography. It's a special test that looks and is dedicated to the small intestine, really highlights small intestine, can help us identify inflammation in the small intestine. It's particularly good for younger people because there's no radiation exposure. So that's really great. You see right across the bowel wall. You can get a good understanding of what is happening. So this is a particularly useful test for Crohn's disease. You can identify strictures. You can have perianal views if somebody's worried about fistulas. And then next portion of this, the downside of these particular tests would be that they're not available in all centers. So not every, medical center always has an MRI. Most of the larger ones do, but some of the regional centers, you may find it's not easy to get to this test. It does require people who have to take some contrast, which can be somewhat unpleasant for people, especially if you're not feeling well. But you can get a lot of information. It can be really useful information to understand the extent and severity of someone's disease. So it can be a very, very, very important test that we do utilize quite a lot in our center. Next slide is, I just briefly wanted to show a little bit on colonoscopy. I know Dr. Bullen just explained colonoscopy and talked about colonoscopy from a perspective of screening for colon cancer. So we use this also in determining ulcerative colitis and diagnosing ulcerative colitis and Crohn's disease. It's basically just a way of putting a small, thin, flexible scope up through the large intestine. You can kind of see, it's showing how the large intestine is being evaluated. You're sedated before the procedure, so most importantly, I don't want anyone to think this happens without sedation. So that's important to know, and it's a really, really helpful test. And one of the other values when doing this is being able to take biopsies or tissue samples so you can make an accurate diagnosis. Next, please. So goals of care for Crohn's disease and ulcerative colitis. So it's very important to understand that this is not a disease that has, or diseases that have cures. So these are chronic illnesses. They require ongoing treatment, usually with medications and management strategies. So you want, number one, for people to feel better. So typically when they're having a flare-up, or there's an exacerbation of inflammation, people do not feel well. So the key is we want people to feel better. That's really important. But we're not content to stop there, nor should you be content to stop there. We need to improve the disease. We need to heal the inflammation and heal the ulcers that are there. We also want to make sure that we're preventing the disease from progressing. So it's very important to intervene early on, prevent progression. This is critical. We want to prevent complications. We don't want people to have to progress to go to surgery if we can help it. So early intervention is super important. And then another big factor is avoid long-term prednisone use, because that has its own set of complications as well. And then next, so a couple words I think of advice from IBD, what can we all do? I think what we can all do is, if you know someone who has Crohn's or ulcerative colitis, really important, build a team of providers that you trust and see your team often, even when you're feeling well. I think the one mistake that our patients make is they only see us during crisis modes, and we're like, no, we're not scary. Please come see us when you feel well. We have so much to talk about and so many other things we need to do to keep you healthy. So please, please, please. Next, be honest, be active in your care. It's really important. You are an active team member in your care. This is not about what we want for you. This is about what you and us want together, and how to help you how to help you feel better. Very important. And this is a whole change in how we approach care. Be proactive, not reactive. It means proactive monitoring, making sure we can find a way to monitor your disease and prevent it from going into complicated mode before things actually start happening. So it's really important. Don't wait for the complications to occur. We want to prevent them from occurring. Know when to contact your GI provider. I think that's always important. Connect with support group. I mentioned this already, Crohn's and Colitis Foundation, I'm biased. And then always take time to do something that you enjoy and something to help on your journey. And then just always know you're not alone, and there's a whole group of people that can help. So thank you.
Thank you very, very much. Appreciate all of that information. And interestingly, that relates to me on a personal level, not family. I should have been clear before I said that. Our next speaker is another Boland, for those of you who are sharp and paying attention here. We have Bridget Boland joining us. And a little bit about Bridget. She is an associate professor at the University of California, San Diego. She received her undergraduate degree from Yale University and obtained her medical degree from the University of California, San Francisco. She completed her internal medicine and gastroenterology training at UCSD, where she also completed an inflammatory bowel disease fellowship. Dr. Boland's research focuses on translational research in inflammatory bowel disease, trying to better understand the disease and predict responses to therapy. She too has received multiple awards, including a Crohn's and Colitis Foundation Career Development Award and others that she's welcome to share. She is the principal investigator on multiple phase 2 and 3 investigational medications for IBD, and she is the director of the UCSD Inflammatory Bowel Diseases Biorepository. So with all of that, go ahead, Bridget, and unmute yourself. Tell us all about it.
Got it. Well, thank you so much. It's a pleasure to be here, even virtually. And I'm going to the next segment is going to be talking a little bit about IBD treatments, as well as some conceptual aspects of clinical trials that we're currently conducting. So next slide. So just briefly, I'm going to talk a little bit about our current therapies for inflammatory bowel disease. I'm not going to get into all the specifics of all the details of everything, because there's a lot, which is good for people. The more therapies and options we have, the better. But I'm going to go over some of the main therapies, sort of the general concepts about them. And they can kind of be separated into a couple different categories. And I'll go through each of them, but mesalamine derivatives, corticosteroids, immune modulators, biologics, which is sort of, a big catch-all for a bunch of the more new therapies, and then small molecules, which I'll talk a little bit more about, but it's sort of a fancy name for the new pills we have that are, sort of a new option for moderate to severe inflammatory bowel disease. So next slide. I think we skipped one. So yes. So one of the older therapies, sort of bread and butter, are called mesalamine basically mesalamine type medication. So mesalamine is sort of the class of medications, the type of drug it is. And there's sort of all sorts of derivatives and different ways this medication is administered so that we can give it to people in lots of different ways. So it's sort of a broadly anti-inflammatory medication that has some relationship to aspirin, yet is very different because for some people, aspirin can actually cause kind of flares for inflammatory bowel disease. This anti-inflammatory medication that actually does not affect the immune system from it's not suppressing the immune system. So it's a really great first-line medication that we tend to give people. There are lots of, as I mentioned, lots of ways to give it. So there's lots of different pills. There's lots and lots of names you've heard for them, from the brand names to the generic names. Some of them include things like Lialda, Azicol, Pentasa, Prizo, many more. Over time we figured out better and better ways to give these pills in, pills that contain more medication in a single pill. So you have to take less pills. Some of them sort of get delivered to different parts of the colon based on the formulation. So they're kind of these smart medications. And when they work, they're really great and pretty well tolerated. They can also be given in different kind of ways. So another way that we can give them is also as like an enema. There's a medication called Rowaza enemas. And so that's basically a fluid that you would insert into your rectum, and it would sort of go up to the left side of the colon, the far side of the colon, and can be a way to sort of locally deliver medication in an effective way. We sometimes use these with pills or on their own. The other thing other way we can use them is as a suppository. So it's basically almost like a little pill, not quite a pill, but a little softer, that you can insert into the rectum and the end of your colon. It's actually a really effective way to locally deliver some medication when the inflammation is right in the end of the colon, as Angelina mentioned, when we have something called proctitis, where mostly the end of the colon is affected. So these have been around for a while. And really, as we learn more about them, they seem to be far more effective for ulcerative colitis and Crohn's disease, but still probably used a little bit for both. And for the right person, generally it's sort of more mild to moderate disease. This can be a great option. And that, it seems to be very effective, very well tolerated. Okay, next slide. The next general category of medications is corticosteroids. So, everyone's probably heard of corticosteroids that are basically these really fast-acting medications that can suppress the immune system, are very effective for stomping out inflammation pretty quickly. As with mesalamine, there are a bunch of different ways that we can give them. There's some of our very potent medications. When you give them by mouth systemically, the probably most commonly used and known one is called prednisone. Again, a very effective way to quickly treat inflammation, but really not a long-term solution, but that can be really helpful when someone has a really bad flare and sort of nothing's helping and we need to buy some time. So can be given usually as a course over a couple months. We generally kind of give people a higher dose and then slowly take them off this medication. If you kind of give someone a high dose of this medication, just stop it, that can be a challenge, mostly because the way the body adjusts to prednisone is it sort of lets it take over your own body's steroid production. And so it can be a problem if you just kind of stop this drug without slowly tapering it down. There's another medication called budesonide. It's another version of a steroid like prednisone, but with budesonide, the steroid actually predominantly gets metabolized by the liver. And so what it effectively does is it can deliver steroids to the GI tract, yet reduce the systemic side effects. So less systemic exposure, which is generally the challenge in sort of tolerating steroids. So that was sort of an advance that we have. And we have a budesonide that gets delivered to the small bowel and one for the colon. We also, much like mesalamine, have some topical ways that we can apply or use steroids. They can be either suppositories or enemas. Again, suppositories kind of go to the end of the rectum, enemas go a little farther up into the small or into the left colon. And so those can be ways where we can administer the steroids locally so you don't have the systemic side effects. So these medications work quickly, and that's why people like them. Why we don't like them is there's lots of side effects. These, really do suppress the immune system, and these are the things that we know are really what drives most of our kind of infections and complications. So, good short term if we need them, but we really know that they are not a long-term solution. They're not a maintenance therapy. They're really a right here, right now to help save the day until we can get to the next step. Next, okay. And the next category of medications is called immune modulators. So these are, in general, pills, although some of these may give as pills or injections, but that they broadly do suppress the immune system, although the immune suppression is relatively mild. But there's a couple categories of them. One is kind of thiopurines, and these are medications you might have heard of, like azathioprine. Another name for that's Imuran or 6-mercaptopurine. Those two medications are essentially the same medication. One's a pre-drug to the other. So they're basically the same medication, just dosed slightly differently. The other sort of type of this kind of medication is called methotrexate. That is a weekly medication given as a pill or an injection. It's given as an injection. Sometimes it's better tolerated that way, and the absorption's a little bit better. But these are medications that sort of at higher doses we sometimes use for things like chemotherapy. We use them in people who have had different organs transplanted. So they've sort of been borrowed from that field, sort of semi-effective on their own, and take a little while to work. So most of these medications really take about 6 to 8 weeks to have a major effect. We use them frequently as what we call combination medications. So in combination with other medications. And most frequently, this is with our biologics, which I'm going to talk about a little bit. And what we think they really do with those is they help sort of boost up these other medications, their drug concentrations, and make them basically our body less likely to react to them. So really, we don't tend to use them much on their own, and they really tend to require a fair bit of blood monitoring, which is one thing that people don't always love. So we'll go back one slide. So just as I'm going to talk now about biologics, but what I wanted to go over first is sort of conceptually what a biologic is, particularly as compared to what we call small molecules. So small molecules are, in simple, they're sort of pills. So they're medications you just take by mouth. They tend to be pretty small molecules. And these are sort of the medications you're used to hearing about. Aspirin, most blood pressure medications, statins, all these medications are pills, that are small molecules. Because they're so small, they can be packaged and put into a pill and taken. In comparison to biologics, there's not the same risk of starting and stopping them. There's no way your body's going to react to them as foreign in the same way that they might with a biologic. Even though, as everyone probably knows when you think about it, pills still can have lots of side effects. And in some ways, they're more systemic, so there's potentially more side effects. Not always, but sometimes. But there's a real convenience factor to a small molecule or a pill. In contrast, large molecules or biologics are basically these huge, ginormous molecules when you compare them to sort of these small chemical compounds that are small molecules. So they're these big proteins, essentially, that in some ways have been derived from, mouse or humans are sort of these big proteins that are human-like. And because they're so big, they're just not stable in a pill. So they need to be given in a different way. And it's usually an injection or an infusion. And that allows them to be stable and go into someone's body. Even though there are, it's interesting. These actually there's a lot of variability in how people metabolize these drugs in a way that sort of there tends to be a little less variability in pills. So lots of variability in how they'll kind of affect someone's body. As I mentioned, because there are these big proteins, huge molecules, in a bad situation or not suboptimal circumstances, our body can respond to it as foreign. So it can think of it can act like a vaccine. Basically, if you give the medication, your body reacts to it. Your body can develop an immune response and sort of chew it up. So the medication essentially is not effective. Different biologics have different risks of this. So some of the older biologics have more risk of this because they're a little less human-like. But this ends up being a big thing that we consider and think about because, we try not to start and stop these medications all the time. That's something that can set you up for some of these issues. On the kind of the really cool side of, why we think biologics are so special is that they're actually very, very targeted. So they're these huge proteins, but they also sort of very, very specifically target a pathway. And that in some ways makes people have less side effects, meaning they're more and more targeted versus a pill deep in your mouth and maybe affects every cell in your body. This tries to go to a specific pathway. A lot of the ones that we use for IBD are sort of very specific to inflammatory pathways that we think are very, very relevant in IBD. As a result, there aren't a ton of drug-drug interactions, meaning, some medications, when you start, you talk to the pharmacy and they say, careful, these drugs are going to interact. These don't really interact with other drugs in that same way. So that is nice. They can have side effects, as with any medication, but again, the targeted nature of them are sort of what makes them kind of special and different. So next, sort of talking about the general categories of biologics. Again, I'm not going to get into all the details of each of these medications, but really the biologics, particularly for IBD, really target the immune system in a very specific way. The first category of biologics that we have were called tumor necrosis factor antibodies. And these block a very specific inflammatory pathway that we know is really overactive in inflammatory bowel disease, both in Crohn's and ulcerative colitis. This is a medication that was actually initially developed to treat sepsis, where someone's really sick in the hospital, and then sort of borrowed, used for arthritis, psoriasis, other diseases too. So these are really effective, sort of fast-acting medications that, while they're they're not new, they're older, they're really effective for the right situation. So they very specifically block this inflammatory pathway, making them very effective. There are specific reasons that we use tumor necrosis factor inhibitors. For example, if someone has arthritis with their GI symptoms, this can be really effective because it treats both arthritis and the inflammatory bowel disease very effectively. So it can be a really effective way to treat multiple diseases that sort of are, consequence of an overactive immune system. So the initial drug that was developed is called infliximab or Remicade, one of the most effective medications that we use, one that we can use to rescue people who are really, really sick in the hospital, and can make people better pretty quickly. That's given as an infusion. The other versions of the tumor necrosis factor antibodies are injections, kind of self-injectable medications, which include adalimumab or Humira, which I'm sure you've seen commercials for, certolizumab or Cimzia, golimumab or Simponi. They're all slightly different, nuances to them, but ultimately, these are some of our older bread and butter therapies for IBD that are very, very effective. The next category of medications for IBD that came out are called integrin antibodies. The most widely known one is called vedolizumab or Entyvio. And this is really, the first medication that was only designed for inflammatory bowel disease. It's not borrowed from arthritis or psoriasis, but really a specific medication for inflammatory bowel disease. what this medication, vedolizumab or Entyvio, does is it prevents these really overactive immune cells from getting to the gut. So it sort of blocks these cells. They have little addresses on the cells that say, hey, you're needed in the gut, blocks them from actually even starting to go to the gut. So it tends to work a little more slowly, not the same kind of onset as the tumor necrosis factor antibodies, but it's very, very gut specific, which people really like. People do very well on this medication. They don't tend to have infections, really, really safe. So it's a medication that we can use sort of for lots of different people, even if they have other conditions, other illnesses, ailments, and not have an interaction frequently or an issue. The next sort of the third class of biologics that have been approved is another sort of cytokine blocking medication. It's an interleukin 12/23 antibody, and this blocks a very specific IBD inflammatory pathway, sort of like the tumor necrosis factor antibodies, where they block this inflammation pathway, but it's one that we think is a little more specific to inflammatory bowel disease. The one that we have currently approved is called ustekinumab or Stelara. And this has been around for a little while. Particularly, it started out in psoriasis. We sort of borrowed it and learned how to use it in inflammatory bowel disease. We think it has a little lower infection risk just because it's a little more specific and tends to be really well tolerated. The first dose is an infusion, and then it's given as a home injection. So lots of kind of differences to each of these medications, but they all have kind of similar concepts. These are, as I mentioned, sort of these designer medications and really designed to prevent complications, prevent progression, and sort of intervene on the natural history so that we help help improve people's lives. And that really is the goal, is to, treat people. And as Angelina mentioned, these are therapies and not a cure. So for now, we know that, people tend to do better when they stay on their medications that help control the inflammation. If you stop them, people the disease tends to relapse and come back. And the dosing is actually very, very personalized for these. So many of these doses can be adjusted for a specific person. Next, I want to at least briefly mention what we call small molecules. So again, like I said, it's a really fancy word for pills. And these are basically kind of new designer pills that have been approved for inflammatory bowel disease. So the immune modulators are kind of these older, non-specific medications that we use for IBD, but these are more designer-specific medications that do impact the immune system in some way, shape, or form, but are specific to IBD and newer and makes them almost like a biologic in how they work, but they're a pill. So there's two main classes currently available. Both of these are actually only currently approved for ulcerative colitis, but this will, I imagine in the future, particularly for the JAK inhibitors, will likely change. So JAK inhibitors, again, a pill, is a medication that blocks multiple cytokine pathways at once. So rather than, say, the TNF inhibitor antibody or TNF inhibitors, which block that's one specific cytokine pathway, these sort of block these areas where the cytokine pathways come together. So it is very effective in that way, but does certainly have an effect on the immune system as because of how it works. So we do, while it's a pill and convenient and easy to take, we still have to monitor blood counts pretty closely. The other thing it can do, this can change people's lipid panels. It can actually make most of their lipids go up, both their kind of good and bad cholesterol. So we kind of watch this. We don't tend to see, complications from this, but we watch them, and sometimes people actually do need to start something like a statin to help control, at least temporarily, these changes. These are really rapid acting, so that's another, upside to these medications. And the current ones available are called tofacitinib or Xeljanz. This is approved for both arthritis and ulcerative colitis. And actually, as of about a month ago, there's a new medication it's kind of a mouthful, called upadacitinib, or Rinvoq, which is approved for ulcerative colitis as well, but will likely be approved for Crohn's disease in the next 3 to 6 months. So a great option. Again, they work quickly, but certainly they do have effects on the immune system that we watch out and monitor pretty closely. The other sort of class of medications that falls into this small molecule category, or pills for IBD, is something, I'm not going to spell out the whole pathway, but it's called an S1P modulator. What it is when I describe it, it sounds a bit like the way that the anti-integrins work, the Entyvio or vedolizumab. But what it does is once there are activated immune systems in your lymph nodes, sort of where immune cells stop before they get to the intestine, they get blocked from sort of leaving the lymph node to get to the intestine. And so that prevents sort of ongoing immune response in the GI tract and is an effective way to treat ulcerative colitis. The one that we have currently approved is called Zeposia or ozanimod. This has been used for MS in the past, so we have a fair bit of experience with it, and have been using it for some time. It tends to be pretty well tolerated. As a pill, there are some drug-drug interactions we have to watch for. We usually have to check a EKG, sort of the heart rhythms, before we start it, because it can cause some changes. So there's certainly some things we have to watch for, but tends to be a really well-tolerated medication. A little less rapid acting as compared to the JAK inhibitors, but a good medication and sort of recently approved, and will likely have some more kind of cousin drugs coming in the future. Let's go to the next slide. So just sort of shifting a little bit, that was sort of a broad overview of sort of what we have currently. I wanted to mention a little bit about sort of future therapies, where we're going, what we're trying to do, what the goal is. So, really what's the goal of these new novel therapies and clinical trials? So there's a bunch of different ways to think about them. One is sort of, we go back, sorry. Is thinking about sort of, we need some new medications that work in different ways. And this is really great for, say, someone who says, you've tried everything, nothing's working. So you want something that works in a totally different way, works on a different pathway. So this is one really important fundamental thing that we work on. We go back. The other thing is sort of, trying to improve our current therapies. So we have a bunch of therapies right now. What if we can make them just a little bit better? A really good example of this is, say, with the anti-integrins, with some of the like Stelara, that we're developing kind of newer versions of Stelara that are more effective, slightly more targeted and safer. So kind of taking what works from the old therapies and making them better. The other thing we're trying to do is create safer therapies. So really trying to make more targeted therapies with less side effects. So, the more locally we can deliver some of these medications, the better tolerated they can be. And then making medications more tolerable, like making them in pills, making it just much more convenient for people.
I'm so sorry, Dr. Boland.
No problem.
Happening here, it won't let me stay on
we're done with that slide. I don't think that slide was well received. So next is sort of, I just want to mention a little bit about, what clinical trials are like. So one thing that I think is hard to really conceptualize, but our typical clinical trials are really, really strict. It's really strict sort of how we try to, who can be involved in the clinical trial and who fits into the right category or the right criteria for a clinical trial. And so when clinical trials are designed, they sort of create this perfect patient who has active inflammation, is off all their medications, so to see how this new drug works. What that means is it's just really hard to get into clinical trials. It's really hard to be sick enough, but not too sick, and meet all the different criteria. And the basic premise is that, we really want to have a good way of looking at a new medication. And right now, most of our new medications are compared to placebo, which is sort of a sugar pill no therapy. And that's because actually a good proportion of people who get nothing actually have some response. So we need to figure out how to compare the new medication to just what would happen, if you weren't on a specific medication. So that's the general way that clinical trials are currently done. That comparison is generally for a very short period of time, meaning it's usually during, there's sort of a starting period. We call it induction, where we're trying to get inflammation under control, where we look at the new medication versus placebo. If people make it through that and don't do well, most of these people are offered this medication if they would like it. And then that sort of takes them into this maintenance phase where we kind of keep the medication going, see how it works. Sometimes there's another time where you have another option to get placebo if you're doing well. But this has sort of been the typical design of trials, is that we compare a new medication against a placebo. It's been a slow system. It takes a while to do these trials. They're really expensive, but people are monitored really carefully. And so we actually get people through these initial kind of early phases of the study that we call induction to make sure they're safely through that period, and stable. We use a lot of endoscopy to sort of monitor and assess the response. And that largely came from the fact that in the past, we weren't using that and we only looked at people's symptoms. And what we found was that we were, finding, basically that we weren't figuring out, we weren't getting accurate answers from our trials. That if we made people feel better, we weren't necessarily actually making them better when we sort of looked at the actual amount of inflammation. So there's been a real push towards making sure we also have really objective measures from these studies to make sure we're really getting people medications that work. What is exciting, and you can get perfect, next slide, this is good, we can get the new clinical designs, is that, we have slowly the world is adjusting and we are learning sort of how to make new clinical trials or, be able to think about clinical trials in different ways. A lot of this is really guided and dependent upon the FDA, meaning kind of national requirements, but there is a shift towards now at least incorporating these head-to-head trials of medications, meaning they'll look at one example was looking at Humira versus vedolizumab. So looking at two effective medications against one another so that we can tell someone, for a given person who has this kind of disease, which medication on average works better. And so, this I think people really like. There's no placebo arm, and generally is something we use when with sort of therapies that are currently available or almost available. This doesn't happen as much for kind of new novel therapies because those we still have to figure out if they're working or not. And there's also a trend towards trying to really incorporate personalized medicine. And this is something that we've really been kind of slow to do, but, say oncology has been really, really good at this and really trying to figure out for a given person, what is a way I'm going to figure out what medication you should be on. And so they're trying to begin to incorporate these into trials, looking for, say, either genetics or some marker in your blood that would tell you might be a good person for this drug, and this would be a really good idea for you, so that we sort of make our medications give them to the right people, which I think is ultimately a really, really important thing that we need to do better with. So that's sort of some of the exciting things coming with clinical trials. Some of the real, I'd be remiss, I kind of told you some of the challenges clinical trials and sort of the confusing design, needing placebos, but there's a lot of potential benefits if you are someone who might actually fit into the strict criteria for a clinical trial. I think one of the really amazing things is getting access to a medication that really won't be on the market for 5 to 10 years. I've seen people kind of get a new drug who've done well on nothing, do amazingly well on in these trials. But you're also giving back. You're really helping to develop better therapies for everyone around you. And it's a service, it's not only you get the medication, but you're really helping to make the IBD world better. Being involved in a research community is pretty special. And I think there's a lot of engagement. Your people are really, really closely monitored. You see your doctor a lot. You see there's a clinical coordinator who, is always checking in on you. So you're getting a lot of really, really good close care and attention. And if things aren't going well, we're constantly adjusting and making sure, you're doing okay. Let's see, I think, and then there's back one slide, maybe.
Yeah, I'm so sorry. I
No,
lost control here.
So just, briefly, we go on to the next slide. There are a bunch of medications that are sort of in late stage development. So, I'm not going to go over all of them, but so the current medication that we have is called vedolizumab. That's an anti-leukocyte, sort of prevents immune cells from getting to the gut. There's some new versions of it sort of in study, blocking sort of slightly similar parts of the pathways. There's the version 2.0 of Stelara, which are anti-interleukin 23 antibodies. There's a bunch of them in study currently already. Some of them are used for psoriasis and tend to be really effective, really fast acting, really well tolerated. I mentioned the S1P receptor modulators, and these are pills. Again, the ozanimod is currently approved, but there are other sort of different specificities of this medication that might work a little better, be better tolerated in study. One is called etrasimod, and that's sort of ongoing current studies and looks really promising. There are also a bunch more of the JAK inhibitors. Those are the pills I talked about that there are currently 2 approved for ulcerative colitis. Upadacitinib is the one that's approved for UC also, but probably will be coming for Crohn's in the next few months. There's a lot more. They're trying to kind of try different combinations where they block slightly different cytokine pathways to make them a little more effective. Next slide. And then, we're really trying to think about out of the box and thinking through other ways of treating people. One thing that we're investigating, although, remains to be a challenge is, can we change the microbiome, affect the microbiome to really treat people? So what we know is, the stool or the bacterial contents in the GI tract are not normal in people with IBD. There's not enough good bacteria, too much bad bacteria. And how do you, if you adjust that, can you make people better? And we know that if, we've seen in studies that if you give fecal transplants, there are pretty promising results in ulcerative colitis, although, the studies are a little bit all over the place of how they're done and how effective things are. So really trying to examine other ways of doing this. Are there kind of easier, simpler ways of doing this with pills or other ways of adjusting the microbiome? So far, the studies for the non-fecal transplant versions of this have not been effective, but I think we're still working on this, and I think there's something there. The other thing I want to mention is stem cells in IBD, and really what that is injecting stem cell or using stem cells to treat IBD, whether it's in the colon trying to treat inflammation and sort of regenerate good immune cells. And also probably one of the more exciting areas that's farther along is using that to treat perianal fistulas. So Angelina mentioned these abnormal connections near the bottom can be really, really challenging, really devastating. And basically we need better therapies. And so this is sort of one thing that's been investigated to help with these fistulas is injecting stem cells into the fistulas to help them heal. So, another exciting development. Next slide. And then I just wanted to mention a little bit more about sort of personalized medicine in IBD and what that means and what we hope it will look like. So this is something that is frequently, utilized in other fields, particularly oncology, where basically they look at someone's cancer and say, hey, you have this mutation, that mutation, you should be on this drug, and think about things in a really rational way, which makes a whole lot of sense. We use a little bit of this in IBD. IBD, but it's not quite that advanced or far along. Things we do is before we start some of the immune modulators, we'll check a blood test to see how you're going to metabolize that drug, if you're kind of a normal metabolizer or not. We also check drug concentrations for some of these medications, particularly the biologics, and adjust dosing for a given person. So not everyone's going to need the same dose. But what I think the future holds is, people have different genes, different immune systems, different microbiome. And really what we love is more personalized testing. So, we could either check some genes with the microbiome and tell you, you might be a perfect candidate for this drug, and your chances of responding are X. And that's what we're working towards, is really being able to match up people to therapies without just having to sort of guess or use our best judgment, which is we learned a lot by treating lots of people, but it's still not perfect. Next slide. So in conclusion, I've tried to just sort of go over broadly some of the therapies for IBD. They continue to evolve, and I think there's, a real focus on trying to make more targeted, more effective therapies. And then also there's been this shift to developing also some small molecules or pills. There are some effective ones available for ulcerative colitis, and we're working on that for Crohn's and coming soon. Clinical trials, they're great options if you're someone who fits into the category of, or fits into the inclusion criteria, but it can be hard. It's it's not. It takes the perfect combination of everything lining up to get into trials. So it's not for everyone. Also, I think it's exciting that we're seeing new types of clinical trials that hopefully will answer questions in different ways and hopefully get more people involved in clinical trials. And then I think we're really trying to head towards a more personalized approach to medicine and IBD, but we're still a little bit in progress. Oh, these are just extra slides. You can ignore these. So that concludes what I was going to say.
All right, thank you. And again, sorry for the mess that PowerPoint became. But with that, we are going to move on to the Q&A portion of this presentation, which is going to be led by Franklin Galis. If you guys could all please turn your cameras back on. Oh, beat me to it. A bit about Franklin before we pass the mic on over. He graduated from Wits Medical School and did his residency in general surgery at the University of Minnesota and urology at Northwestern University Medical School in Chicago. He's been in private practice as a urologist for over 30 years and currently serves as the Chief Scientific Officer at Genesis Healthcare Partners and is a voluntary professor of urology at UCSD as well. So Franklin, go ahead and lead us with the Q&A.
Thanks, Kaylee, and thanks to Rick and Bridget and Angelina for just a brilliant three-part presentation. Fascinating information. I really learned a lot. So at the moment, I don't see, let me see if there is a question here. So there's a question that I think for Bridget, where can one get fecal microbial transplants? So Bridget, can you answer that question?
Yeah, so unfortunately, fecal microbial transplants are currently only available for inflammatory bowel disease in clinical trials. They are approved by the FDA for recurrent C. diff infection. So basically a recurrent infection that occurs more frequently in people with inflammatory bowel disease, but you are not, but is not approved currently for inflammatory bowel disease. And the FDA is actually very, very strict on regulating this. That you need an investigational license to do a fecal transplant outside of recurrent C. diff. So hopefully we'll be, I think that's where the real interest is, in sort of trying to create ways of harnessing what we get from a fecal transplant, but realizing that they are, currently restricted. And then COVID also led to further restrictions on our sources of stool. So it's been, even more challenging than it previously had been to get sort of our fecal sources for recurrent C. diff right now.
So I didn't see any other questions. Please, anybody, if you have questions, go into the question and answer section. Rick, if I may ask you, what are the predisposing factors of conversion of benign polyps to malignant lesions? What's that process? What do we understand? You have a benign, simple polyp, and then one day it becomes malignant. What's a transformative event, do you think?
Well, it's mainly just an issue of time. So in 1988, there was a big breakthrough. There was this guy at Johns Hopkins named Bert Vogelstein who developed, who looked at data and had a brilliant leap, an intellectual leap, and he recognized that what was happening was that in normal tissue, you would start off with a mutation in a gene that regulated the proliferation, the division of cells. So that would be the starting point. Now, initially, it looked like there was this one gene, the APC gene, the one that causes familial polyposis when you have a germline variant. That would start things, but then there were other ways to disrupt the proliferation. And now you had normal-looking tissue that would grow a little bit faster. And as it would grow a little bit faster, it would accumulate new mutations at a slightly higher rate. And most of those mutations are meaningless. They're just passengers. They're just little errors, little bitty typos, if you will, that don't. So, a typical typo in a whole book doesn't change the meaning of it. But every now and again, something comes up that really changes things. And so then there's a series of other genes that get mutated by chance because the cells are proliferating a little faster. And certain of them accelerate the process more. So probably a typical period of time from the appearance of the first mutation that makes the cells grow faster until you get a cancer is probably 25, 30, 40 years. It takes a long time. Now, what happens is that there are certain things that can make those mutations occur at a faster rate. So a high-fat diet and meat in the diet make that they give extra nutrients, and the epithelium grows faster. Or smoking, and a few other things too, that will increase that. And so at some point in time, the tissues grow faster, and they make a bump or a polyp. And then when you look at it under the microscope, it looks a little different than the normal tissue. And then eventually there's a critical point where this benign polyp picks up a mutation. And we know what genes are involved, the P53 and a few other ones. And then the cell goes from being a benign neoplasm to being a malignant one. Now it's Katie bar the door. Now you're talking about, months or maybe a year or two until that becomes an advanced, invasive, metastatic disease. So it's the gradual accumulation of mutations that is responsible for the growth. And interestingly, that's why, even though probably somewhere upwards of 50% of the population will get a polyp, a benign polyp in their colon, only about 5% will ultimately get a cancer.
I see. There was another question about how can we prevent some of these diseases? For example, are there diets? Are there natural medications? And before you answer it, let me throw this question. We used to think that alcohol in moderation was actually good. And we've come to learn that alcohol, probably even small amounts of alcohol is bad for us. And how does alcohol affect the GI tract? And should one totally abstain, or a moderate amount of alcohol is not going to impact our GI tract? Any thoughts there?
Is this for like a cancer consideration or IBD?
Well, cancer and IBD. You talked about smoking. I think most of society are aware of the side effects and the risks of smoking. But I think alcohol is still so prevalent in our society, and we're learning a lot. What do we know about alcohol, the amount affecting the risk of malignancy in the GI tract and IBD?
Well, my opinion would be it's probably true that there's no completely safe dose of alcohol. But alcohol hasn't come up as a major factor in colon cancer, but it's something of a minor factor. And it's just the way that so alcohol is a really small drug. It's just 2 carbons and a few oxygens and hydrogens, but it gets metabolized into other compounds that can be annoying to DNA and mutate it. The other thing that probably happens is that that alcohol probably changes the microbiome, as Bridget was saying. And so right now, we just don't know that much about the specifics of how modifying the microbiome leads to cancer in humans, but in laboratory animals, it's really clear. You can add 1 or 2 unique bacteria and make a much more carcinogenic situation. So there's probably no dose that's of alcohol that's truly completely safe. And in terms of the overall impact on colon cancer, it's relatively modest.
Well, thanks for that. And then to answer the other question, are there any natural foodstuffs or non-medication things that can you take if you're worried about getting IBD, if there's a preponderance in the family? Is there anything that one can do, quote unquote, naturally? Bridget, Angelina, do you want to take that one on?
So I'll start, and then I'll have Bridget chime in because I know she'll have other things to add. So I'll start with this. There's a number of things that research is looking at this very significantly to see, what can be helpful. Are there, quote unquote, natural things we can do, or even diets we can do that might help? There's been a really nice So there's been a very large study now in the last couple of years that's looked at what diet might be helpful for people that have mild Crohn's disease. And they were looking at 2 different sets of diets. This was actually funded by the Crohn's and Colitis Foundation, which is worth mentioning because they're a nonprofit organization that is dedicated to the lives of people that have ulcerative colitis and Crohn's disease and dedicated to trying to find cures. Well, they're putting an awful lot of money into research. So one of the big things they looked at was a particular study looking at the Mediterranean diet, which has gotten a lot of press from an overall health perspective. From a health perspective of looking at maybe decreasing risk of cancer, cardiovascular disease. And it's been talked about now for, I want to say, as long as I can, I'm going to say at least probably 20 years. And it's been discussed. And they were comparing that against another diet called the specific carbohydrate diet. And essentially what they found was that they finally were looking at, does diet decrease inflammation inflammation that is caused by IBD? This is different than people just saying, I feel better on X, Y, and Z diet, because that's more symptom driven. And we don't really understand, in the past, we haven't really understood, does that mean that someone's Crohn's or ulcerative colitis is getting better? So finally, this large study was done, and it looked at this specific carbohydrate diet versus the Mediterranean diet. And lo and behold, it was found that the Mediterranean diet does look like it is a factor that it can help decrease inflammation. And I think a lot of people, took away from that maybe there's something to be said for, and other research that's shown us that maybe food preservatives, additives, I mentioned before, emulsifiers, things that you might find in fast foods and processed foods might be detrimental and might actually be problematic in the development of Crohn's disease or ulcerative colitis, and that maybe people would actually do better to remove those from their diet. So that would be something for us to think about. There's other areas, there's lots of areas you can kind of go into here where turmeric has been, looked at as an agent. The problem with a lot of these sort of natural studies is that they've not been They've not always been large. They've not always been well funded. They've not had enough people maybe powering them. And so when that happens, it's hard to understand if those are real findings that kind of occur. And some of them don't also include objective measurements. So Bridget was mentioning an awful lot about some of the objective measurements of inflammation, like, blood work and biomarkers and stool tests and colonoscopies. But we need to know that therapies we're going to recommend are going to have ways of decreasing inflammation. And it's important to feel better, but we know that the main driver of Crohn's and ulcerative colitis is ongoing inflammation. So we have to do more to decrease inflammation. So I know it was a long answer.
Thanks. Bridget, do you want to add anything to that?
I don't have a ton to add. I think, we're trying to figure out how to prevent disease is really complicated and is sort of something that requires, thousands of people. So I don't think we have a great answer to that. And so we're sort of, left with, utilizing what we know from IBD and, trying to be rational. And so I think, logically, we want, it'd be nice to find something natural, some natural way to prevent or reduce inflammation. And so I think Angelina nailed it that, something like a Mediterranean diet makes a lot of sense for a lot of reasons. Is probably a really reasonable thing. Trying to get your fresh foods, lots of fiber and fruits and vegetables in your diet seems to be good for just about every aspect of health. And so I think, when you apply that to inflammatory bowel disease, it's probably one of our best ways of trying to prevent inflammation at this point. But also knowing that, the immune system is really powerful. And if you're someone predisposed to getting this disease, you might still get it. And so, I mostly say that because, you don't want to beat yourself up if you get one of these diseases that you're just, set up to get. Some of this is out of your control, unfortunately.
Wonderful. Thanks.
If I could just pipe in here. I thought it was interesting that you brought up curcumin, because I had a colleague who is Indian and who was always doing an experiment on the side with curcumin. And curcumin has like these amazing anti-cancer effects in the laboratory. And then if you take a look at the international risks of colorectal cancer, India is conspicuously low. But there are a lot of vegetarians. I guess over half the population are vegetarians. But if you take a look at the part of India that eats the most curcumin, they have the lowest incidences of colorectal cancer. So there could be something there. He's even written a book. This guy's name is Ajay Goyal. He's written a book about curcumin, and he and the nice thing is there appears to be a relatively little downside to curcumin, and certainly to the Mediterranean diet, or a low fat, low meat. I mean, what are the risks there?
Thank you for that, Rick. There was another question about gluten. Does gluten have any impact for IBD or colon cancer? Is there people are gluten sensitive and they get symptomatic response if they're intolerant of gluten, but does it affect the diseases we're talking about?
We're not aware yet that it does affect, there's not data per se that gluten specifically affects, the inflammation that's driving Crohn's disease or ulcerative colitis. But yes, certainly there are people that feel better when they're on gluten-free diets and that their symptoms are decreased, especially when it comes to gas, bloating, abdominal discomfort, those types of things. But there's not necessarily clear data that being on a gluten-free diet would necessarily help Crohn's disease per se, or that prevent, Crohn's disease or ulcerative colitis from occurring in someone who's genetically predisposed.
Thanks. One last question, and then we're going to wrap it up because I want to be respectful of everybody's time. And this was a brilliant symposium to all three of you. Thank you for the great information. Rick, villus adenoma is a different type of polyp. And the second question is familial. If you've got someone in your family has had a villus adenoma or other types of polyps, should one be more cautious in terms of one's own screening regimen, like get screened every 5 years? What are the guidelines currently recommend?
Yeah, I don't think that villus adenomas have any particular familial aspect to them. A villus adenoma, if you look at it under the microscope, it looks a little bit like it's got hair on it. It's got like villi or, hair on it. And it's just because the epithelium is growing faster than the stroma. In other words, the underlying, it's like the grass gets long because it can't grow down into the dirt. So it just grows faster. And I think that it just means they've accumulated more growth promoting mutations, but there's no particular familial aspect to it. Most people who have familial polyposis, they get a bunch of polyps and they're pretty small, and they're not particularly likely to have villus adenoma. So if your first-degree relative has a villus adenoma, I just take it as that's an advanced adenoma. It's an advanced polyp. It has that risk. But advanced adenomas can be large, bigger than 10 millimeters, have villus features, or have another feature called high-grade dysplasia in there. And all of them increase that person's likelihood of developing a cancer at that spot. But I don't think that passes over to family history so much the way cancer does.
I see. Well, I think it's time to end this symposium. Again, Bridget, Angelina, Rick, thank you so much for supporting SAGAC. We're most grateful. And to Kaylee and Pam for coordinating this, and to everybody who attended, good night, and look forward to another medical symposium soon. Thank you.
So long.
Thank you.
Thank you, everybody.